Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more.
In today's Mayo Clinic Ophthalmology Podcast, Dr. Sophie Bakri and I sit down with retina specialist Dr. Joan Miller from Harvard Medical School and Mass Eye and Ear. Tune in to hear about her leadership journey and remarkable career in advancing macular degeneration treatments.
Today we're honored to welcome Dr. Joan Miller, the David Glendenning Kogan Professor of Ophthalmology at Harvard Medical School and a renowned retina specialist at Mass Eye and Ear. Dr. Miller has had a remarkable career as a clinician, scientist, mentor, and leader. Her pioneering work helped establish photodynamic therapy for age-related macular degeneration and contributed to the development of anti-VEGF therapies that have transformed the lives of millions of patients worldwide. Beyond her scientific contributions, she has spent more than 2 decades leading the Harvard Department of Ophthalmology and mentoring generations of ophthalmologists and vision scientists. Joan, thank you for joining us.
Thanks so much for having me.
I must admit, I'm the only retina specialist here at this podcast, and so I have really enjoyed meeting you today and sitting down and learning about your remarkable career. And I just for our listeners, because we have ophthalmologists far and wide that tune into these podcasts, share with them, as I've learned, because I'm in peds, I'm not a retina specialist, share with them your background in your leadership journey, your research journey, your retina journey to where you are today.
Well, thanks again. I will try to be short on that one, but I was drawn to retina within ophthalmology because the surgery was so much fun. It was not predictable. You often had to problem solve while you were in the eye, and that appealed to me. And of course, there were diseases that were not well treated. So that led to research, which ended up being really about macular degeneration, although it started more broadly. And I really enjoyed being able to go from the lab to clinical trials and then actually to have things that were successful for patients was really just wonderful. And I had never planned to be a chair of a department. That was not on the list, but I ended up doing that, and it was really, really rewarding. I stepped down in November after 22 years, and now I'm rediscovering how much fun it is to be full-time in research and clinical care.
Wonderful. I found out a little bit more about your research. I thought about retina once upon a time. That was prior to anti-VEGF and some of the modern surgical things. But the main treatment I learned how to do when I was a resident was PDT. And you were sharing with me what a fundamental role you had in your career in developing PDT. So can I learn a little bit about that part of your journey?
Well, sure. I was interested in abnormal blood vessels that affected retinal diseases and worked in animal models that had those abnormal vessels, really starting with Judah Folkman, who was trying to develop anti-angiogenic drugs. And so I developed the model and was testing these anti-angiogenic steroids, and nothing was working. And I wanted an ARVO abstract. And others in the lab were using photodynamic therapy to treat intraocular tumors. So I said, well, we could try this to close off these abnormal iris vessels. And we did that. I got my ARVO abstract in a paper, and I was really kind of hooked on PDT. So when I had the opportunity as a faculty member, really began the more serious work to try to develop that as a treatment.
Yeah, I remember those early days, and it was just the resident on services. But can I ask, for Dr. Bakri too, what diseases are currently treated with PDT versus anti-VEGF and all the things we have now?
I mean, that's a very complex question. PDT was really the only treatment we had for macular degeneration for a long time before anti-VEGF. And then we started using combination therapies. And now it seems like anti-VEGF therapies, which again, Dr. Miller pioneered, have really taken over. But there's still a role for PDT, central serous retinopathy, very few cases of macular degeneration, and of course retinal, hemangiomas. We still have a machine, and it works well, and it's all about patient selection. So Joan, after 2 decades of leading Harvard ophthalmology, I'm sure it's a great time now to reflect upon your wonderful career. You've told us about, the PDT, the anti-VEGF. Are there any pivotal turning points in your career that really helped shape your professional journey?
Well, I think it has been a year for reflection. I think after 30 plus years in the profession, it's natural to do that. And I guess I have to say that in looking back, I recognize that it's really all about the people. And I was blessed to have wonderful mentors. First in the clinical realm, Don D'Amico and Evan Gregutis really taught me everything that I ever knew about surgery and medical retina. And Judo Folkman, of course, on the science side. And then Ephraim Friedman, who was very much interested in macular degeneration, was a research mentor, but really it was more of a leadership mentor. And he was really the one that encouraged me to throw my hat in the ring to be chair. It was not something I'd ever thought about. And he said, you've had these great successes, but now it's time for you to get back to the institution and provide an environment for young people to be able to succeed. So those mentors were wonderful. I had really wonderful collaborators. Tony Adamus and Pat DeMore were certainly two of the key ones. And now I'm just really blessed to be able to work with a great group of retina specialists and clinician scientists working on macular degeneration. Some are not as young as they were when we started, but we have an ongoing crop of developing wonderful young stars.
Yeah, well, it must be nice to see the young stars that you developed and helped and resourced as your time as chair now, really kind of running the lab and being part of that again. That must be very rewarding.
Yeah, I think the best part of being a chair is the people. It's being able to mentor people and empowering them to succeed in reaching their career goals, and that really has been the best.
Yeah. So throughout your journey, were there any risks that you took, or initiatives that you thought might be risky and ultimately just proved to be transformative?
I mean, I think all the steps of your career and your life actually end up being a risk of some sort. I had no doctors in my family, so I really had no idea what I was getting into. And then as I was finishing my training, I didn't have any knowledge of anyone in academics. I wasn't sure that I was smart enough to be in academics, and asked Joe Rizzo, who was one of my senior clinicians, whether I was smart enough, and how do you figure out the questions to ask, and how do you write grants and everything? He's like, yeah, Joan, I think you're smart enough, and you'll do fine. So I think it is about pushing yourself a little bit and daring to try something. Certainly being a chair, after just being promoted to full professor the year before, and the first woman, like all that stuff was a bit scary. I remember driving into work in the first weeks of being chair and thinking, first of all, if I screw up, that'll set back women for another decade. And what can I do that's wrong? I used to listen to the music from Les Mis as I drove in to kind of get me bucked up for the day. But it all worked out.
I appreciate Dr. Bakri as a chair, just as a mentor and a continual encourager for me and our faculty, and I'm sure you were the same as a chair. Looking back and just thinking about these risky moments where you took on something that you didn't know whether your wings would fly in the same way they'd been flying before, whether it's a move from this phenomenal clinical and research engine to being a chair. And now there's certainly this leap into something new that you say you're blessed by this new experience. But what advice do you have for young faculty as they look at new initiatives or right turns in their practices that seem overwhelming or too risky?
I think you need to reflect. You have to know yourself. So you really need to think about whether this opportunity that's being offered is something that really fits with what you view as your core beliefs or mission, or however you're going to phrase that. And sometimes you do have to say no. I mean, I remember early on being asked to run a review course that occurred in the summer, and I was a junior faculty member, and as the chair asking me, I thought, how do I say no? You're sort of brought up to think you never say no. my husband, of course, had his own views on the subject. But I went in and I said, no, I think I can't do that. And again, Don D'Amico, who was on the faculty there, was like, how did you learn to say no so fast? That's pretty smart. So it is, thinking through, how it's going to affect you, what it's going to do in your life. And, you only know the path you took. Yeah. You don't know what you missed.
Yeah. Many young faculty really aspire to be clinician scientists, but yet the path is increasingly difficult and it's quite intimidating. What advice do you have for those looking at that pathway?
I think it is a challenge to be a clinician scientist. I don't think that's new. I mean, whether we're at the worst point or a good point, we can argue. I think when Tony and I were in that part of our career, we were told by senior people that the year of the clinician scientist was dead and that it was a really bad idea to be doing that, and we obviously ignored that advice. And I think it's still a worthy pursuit, and I think it helps to have supportive leadership, certainly, that recognizes that, and it's also helpful if you can have more than one in a department. I think you need to have a cluster who can support each other and sort of convince and share with each other that they're not crazy, that this is really something worth pursuing. Clinician scientists really help bridge the clinical problems and the scientific advances. And it's partly a language translation activity, but I think it's still very important. And we really have tried to promote that in our department.
Yeah. It's like doing 2 full-time jobs at once, right?
Yes.
Yeah.
Although I also counseled, maybe it might have been more women than men, but it's really both, that as a clinician scientist, you are trying to get 2 full-time jobs done, but they're not at the hours that are prescribed. I think sometimes it's harder to be in private practice where you need to be in there, in those weekday, if not more hours. And, as a clinician scientist, you could work through the night, so you have more opportunity. You don't have to be there during normal business hours. So it was helpful, I think,
so
having a family. Yeah.
That's flexibility,
I guess. That was flexibility for the family.
So in talking about the challenges of being a clinician scientist, so many people in the lab appreciate there's lots of little steps before a big discovery is made, and there's lots of missteps and a lot of things that don't work out. We started out earlier in this podcast just touching on the remarkable journey in developing PDT. A lot of our trainees now take for granted instrumentation, surgical steps, and may not appreciate how there were individuals behind them that had an idea, that creatively invested it, that did the rigorous research and brought things that changed practice for all of us. And it's an opportunity for them to do similar things. But can you share, in talking about risks and or in the rewards, what you brought up the concept that from tumor management, the PDT ID was there to treat ARMD. Can you share just a little bit about risks and rewards early on in that journey?
Well, I think certainly in any of these, you have to start with the clinical problem. And I think, as a clinician, you see the patients who are not being treated as like you'd like them to be or have the outcomes you'd like. And so it drives you to pursue questions. And then it's having the expertise and the availability of resources to figure out how to test those and pursue them. And you don't know if it's going to work. With PDT, as we got into treating the choroidal neovascularization in the model, we used the same treatment parameters, and some of those meant that the treatment time was going to be 16 minutes, sitting there with a lens on the eye trying to focus on the macula. And I could do it, but I thought, no retina person's ever going to do that, and so we need to turn the irradiance up. Well, the teaching in the field was that if you do that, you'll have pain and heat, and that's a terrible thing. You can't possibly do it. And I was like, well, maybe not in the eye because the choroid's a heat sink, and maybe we can try it. So we did. We went way up on the irradiance, up from 150 to 1,800 milliwatts per square centimeter, with no problem, and found 600 was very effective, and that's actually what's used in patients today. But it was, you have to try something that may go against what the teaching is in the field. And so again, I guess that's another little risk, but it's sort of, you have to be willing to try to pursue the problem solving.
And I need to say a personal thank you. One of the most fun surgical adventures I ever had was as a strabismologist, managing patients that had macular translocation to move the ARMD away from the fovea, and then you treat that, but they walked in with a tilted world, and I got to put their alignment back. They were the best. It was just one of these most remarkable, usually in monocular patients, but a phenomenal, fringe component of PDT treatments.
Right.
Well, we're fortunate that we don't do those anymore.
Yes,
so,
exactly.
And that's a testament to how the field has advanced.
So share with us a little bit about, because now you've gotten into anti-VEGF care and research. So where does that stand in terms of your role in your lab over the last years and decades?
So at the time we were developing PDT, we were trying to figure out what drove the vessels, and that led to pursuing VEGF as the target. And that, again, really came out of tumor research. It was a question that ophthalmologists have been looking at since the 40s with Michelson, wondering what factor X was that came from ischemic retina and caused these new vessels to grow. And people had looked at various factors that didn't really pan out. But when both Harold Dvorak and Napoleon Ferrara separately identified a secreted permeability agent that also was an angiogenic factor, was also secreted by hypoxia, that really all fit for factor X. So we and others in Harvard and beyond, although it was sort of multiple teams at Harvard that really were pursuing this, looked at VEGF and went through a variety of steps to prove that it, was in the eye. It did go up with new blood vessels. If you blocked it, you completely prevented the new vessels. And if you put it into normal animal eyes, you could recapitulate everything that we saw. So that really demonstrated that targeting VEGF was going to be viable. Interestingly, most of the data was in these ischemic retinopathies, not in AMD, but AMD was where the treatment need was greater. And people were not clear how we were going to treat it. It's sort of hard to think about that now because intravitreal injections are so blasé. But at the time, people thought patients would never tolerate it. So sort of to your point, patients tolerated macular translocation and strabismus surgery, and they were more than willing to undergo monthly injections. I mean, that was, that's worth it if you're going to go blind otherwise. And the results were so remarkable. But again, that was something that, people struggled with for a while. We looked at other ways to deliver the drug.
Yeah. So, I mean, it takes a special something to contribute, above and beyond, right, our daily job. And, I'm sure you meet so many young people. And what makes you think, somebody really has potential, to be a leader in the field or a leader, in the community, a leader in ophthalmology? I mean, there's so many ways to lead and bring things forward. But what sort of characteristics do you see that push that forward?
Yeah, I don't know that I'm good at identifying individual characteristics, but I do spend time with the younger people that I'm helping mentor to really understand what drives them and what excites them. And I think it's obviously a discovery for them also that they really need to think about what it is that makes them want to get up and come to work in the morning. And if it's as you say, it may be different things. Some people like to get involved in professional organizations, and that can be really vital. They want to help with policy and learn more about that. They end up in quality careers. There's so many ways to contribute, and I think it's more sort of having conversations with them to help them learn and understand what it is that's going to make them feel like they've contributed. And
do you find the types of people that are passionate about everything, and how do you coach them?
That's a good question. I think, it's fine to be passionate about everything at some stages, but eventually you probably have to pick. Mm-hmm. But I think it's hard as the mentor. You can't tell them, right? They have to figure that out on their own.
But it takes time. Is what you're saying.
So through guidance and encouragement, so many people have remarkable successes, as your career is an example of. But as a chair, and certainly in the lab, sometimes people are underperforming or maybe not actually putting in the hard work that it would take to achieve those goals. Advice for us as we mentor, it's always nice to be a positive mentor, but do you have any advice over, as a chair when you're encouraging a clinician scientist or just anyone in our teams when expectations aren't being met? What would you advise?
Again, I think you end up trying to sort out with the individual, like what are the problems? I mean, is there a health problem? Is there something at home that's happening? Without obviously being intrusive. But if you're trying to be supportive, to sort of sort through some of that, and sometimes it's just people are in the wrong job, or it's the wrong fit for them. They don't like what they're doing, and they need to be, you need to help them recognize that it's not going to work for them.
So I want to hear, you've had remarkable aspects of going into a retina practice, that you have your fingerprints all over PDT, you have your fingerprints behind Avastin. What's coming, either in neuroprotection or in statins or in whatever it might be? What excites you now about researching?
Oh, there are lots of good questions. I mean, I am still pretty focused on macular degeneration, and I think, as my mentor F. Friedman told me, why are you wasting your time on the end stage of the disease? You need to be treating earlier, and that's still where the sweet spot is. I think we want to find treatments so that people never lose vision. Our group believes that the early and intermediate forms are actually multiple subtypes of the disease and probably driven by different pathways, and that they will need to have different treatments. And then when you get to a certain stage, we all sort of, go down the same paths of angiogenesis or atrophy. So I think trying to tease out those different subtypes and then identify pathways that we can target is where I'm excited. I am a big proponent of neuroprotection. I think that's still, got a lot of potential for a variety of diseases, and I expect that there'll be some interesting things coming out in the next few years.
Yeah, I mean, with anti-VEGF therapy, it's been around for a while, and there seem to be lots of incremental improvements in anti-VEGF therapy and duration. But at what point do you say it's time to look at different mechanisms of action of drugs, but also different mechanisms of the disease that we need to look at?
I mean, I think what was actually surprising was how key VEGF was in the neovascular and permeability process in retinal vascular disease. I mean, that surprised us. I think we were excited to find, factor X or whatever, but we actually did think it was going to be a cocktail, and there'd be other agents that you'd need. I think it depends on the condition. So I think we have figured out how to deal with the permeability. There might be more to do in DME and retinal vein occlusion, edema. But I think what we're missing, besides the early stages, is that we're treating degenerations, and that the retina becomes atrophic not because we're under treating, but because it's a degeneration. And I think figuring out how to stop that is something we need to add.
Yeah.
So I agree. The next 18th anti-VEGF drug doesn't really excite me, but some of these other targets does.
Yeah. And it's really inspirational to see, the amount of research, the discoveries that you've made from an academic medical center. There definitely, seem to be questions with funding changes about whether industry is the way to go to realize, the transformation. What are your thoughts about academics, the role of industry, the role of collaboration, and do you think that there will be cycles of this?
Yeah, I think the models do change. I think, Judah Folkman actually was an early proponent of partnering with industry because, industry is better at running clinical trials and developing drugs. And so I think the ideas in early stages can come from academics, and, we may be better at that because we don't think of timelines in the same way. But I think you do need industry partners. But it has changed from Folkman's time, where you could identify a target and license it, and now it seems that people want you have to do a startup, and then you have to get human data, and sometimes it's hard, particularly in the funding environments, to actually accomplish that.
Well, what you've done has been very inspiring. Taking it from an idea from the lab to commercialized drugs. So thank you for that inspiration.
Thanks, Sophie. Thanks, Eric.
My last question would be, it's hard, you seem like the type of person that thrives and is challenged and rewarded whether in the clinician role, in a research role, and in the leadership role, mentoring and being an advisor. For some people, it's hard to step down from prominent leadership positions. You seem to be very comfortable in your skin now after 22 years of a prominent leadership role. Now you're running with the clinician scientist role again. advice for people? Because for some that's a hard transition to do, but advice for people listening that are stepping away, whether voluntary, involuntary, whether health reasons, where they can't do what they've always done, but yet there's certainly hope for the next journey.
Well, I think, when you can plan for a change, that helps you. Whether it's good or bad or growth or shrinkage, I think that can be really helpful. And you can't always predict, and you have to, recognize that, and be comfortable with the contributions that you were able to make, and not beat yourself up too much on the mistakes you made, and then wake up and think what's good to do today. And it's great to be healthy and to be able to do things and have a great family, great husband, good friends.
Wonderful.
I would add, though, she's not stepping away from something, she's stepping into something. So, and certainly Dr. Miller has many things that she can step into, and probably that she's been looking forward to stepping into and continuing the contributions.
Well said.
So,
well, thank you so much for joining us, sharing this time and your insight and your history and your vision with us. It's been inspiring to get to know you.
Great. Well, thank you so much, both of you, for inviting me to come.
thank you, Joan, for joining us.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.